Good morning, sir.
Morning, Santosh. Please start.
Yeah. Today we are going to talk about medial open wedge osteotomy, open wedge tibial osteotomy indication and planning. So, knee osteoarthritis is most common in age, very common, and this is due to articular cartilage damage. And varus knee is very common in Asian population. So, in varus knee, it may be unicompartmental osteoarthritis or tricompartmental osteoarthritis. So treatment option for those are conservative management, chondroplasty, that is arthroscopic debridement, osteochondral graft, tibial osteotomy, medial open wedge osteotomy, and lateral closing wedge osteotomy, unicompartment osteoarthroplasty, and total knee. Now today we are going to talk about the tibial valgus osteotomy, open wedge osteotomy. Why osteotomy? In young active patient with medial compartment OA is common. It's for those patients we can't change the knee by plastic. We can't do plastic because of the survival rate of the implant. So we for those patient active young adult we'll do osteotomies in the medial compartment. So then osteotomy impose no permanent activity restrictions and locked up results of total knee arthroplasty or unicompartment knee arthroplasty in young adult are not satisfactory. And in osteotomy, it preserves the natural joint, and there may be need to correct malalignment when performing chondroplasty and ligamentous reconstruction. And this is superior results are more like with compensatory complementary fixation. In Asian population, religious rituals and traditional habits call for full flexion of the knee. These are some few examples we'll perform for full flexion of the knee in Asian populations. So, what is the concept for tibial osteotomy? That is change in the mechanical axis, by from medial to lateral, which improves the loading distribution and helps in cartilage regeneration. The why in this picture the mechanical axis, the first pre-op picture is the blue line where the line of mechanical axis is shifted from medial to lateral, and the second picture, this is the article where pre-op pictures show that articular damage in the before HTO and 1.5 follow-up of HTO. Then what is the goal? Our goal is for the patient for pain relief, functional recovery, and withstand heavy functional demands. So, according to Coventry et al., he said that he had a long-term follow-up of 5 years of 90% good result when doing tibial osteotomy, and 70 to 80% 10 years of follow-up. And he said that good alignment means more than 8 degrees of valgus. If the alignment is less than 8 degrees, it may result in poor result with residual varus, and we have to keep in desired final alignment, that is from 8 to 10 degrees of valgus. And long-term results depends on correction of achieved union until the union is achieved. So conventional tibial osteotomy has complication mainly on inadequate correction. It accounts for 20%, especially in cross-wedge tibial osteotomy, and recurrent varus in 5 to 30% of cases, and least in patient may have nerve injury and vascular injury. And regarding surgical demand for good tibial osteotomy is precise, safe, and versatile correction. Correction should be done. Then stable fixation to withstand the correction, and it is a less invasive and it has less invasive method and less complication. And patient may have fast rehabilitation and shorter hospital stay, and it is very easy to convert to TKA. A study done in 2011, open wedge tibial osteotomy with locking plates, that is Tomofix, for treatment of medial monocompartmental osteoarthritis by Alex Stobley, and he has done totally 92 open wedge tibial osteotomy. In that, all are united and no loss of correction, and the patients are early recovered. So comparison with tibial osteotomy, open wedge and closed wedge. So in open wedge there is a need of bone grafting, but in closed wedge we don't need of bone grafting. But bone loss is not seen in open wedge osteotomy. It is seen in closed wedge osteotomy, and technically it is potentially easy and whereas closed wedge is demanding, and intraoperative adjustment is very easy. It's good, very easy in open wedge osteotomy, and there is no need for fibroid resection, And during dissection, peroneal nerve injury is not there because we are doing in the medial aspect. Whereas in the closed vigil, there is a danger in the peroneal nerve and patient may have foot drop. And early rehabilitation is common in this. Early rehabilitation is common. Is good in open wedge, and conversion to total knee osteoplasty is easy in open wedge. So, according to medial open wedge tibial osteotomy in tomography, the indication is isolated medial unicompartmental osteoarthritis and were not normal contralateral and femoral joint OA, femoral joint osteoarthritis. Whereas age is 40 to 60 years and BMI is less than 30 degree, high demand activity, metaphyseal varus, and alignment should be less than 15 degree. And later they said that there is no limit in age and alignment should be less than 10 to 12 degree for this patient. And a study by Marco regarding this indication, the age limit is a systematic study and the age limit is less than 56 years and knee flexion should be more than 120 degree and flexion contraction should be less than 5 degree and BMI is 25 to 27.5 degree and also is grade 1 to grade 3, grade 2 and pre-operative score is WOMAC score should be more than 45. And regarding instability, if it is the patient with ACL tear, acute ACL tear with double varus, we can do in a single stage procedure. If it is a triple varus with patient should go for 2 stages. First, we will correct with correction of ACL, and if after open relay, if the residual instability is present after 6 to 8 months, we will go for PCL and posterolateral coronal reconstruction. And patient who are unsuitable for middle open wedge osteotomy or flexion contraction is more than 25 degree and bicompartmental disease, prior knee infection, and elderly patient with difficult mobilization, obesity, and X-rays shows atrophic bone and severe tibial and femur bone loss, and smokers. Regarding summary of this one, the HTO is biological treatment by correcting the mechanical axis. Procedure has been evolved and reliable and safer with open wedge with tomofix. And closing wedge osteotomy has been a role for especially for severe varus deformity. And osteotomy is all rolled out and it's a regenerative medicine. And coming to pre-planning in medial open wedge tibial osteotomy. So there is we are correcting the frontal pain. The correction is mainly in the frontal pain from valgus to varus to valgus. And we have to take a long weight-bearing X-ray for all the patient. Why long X-ray? See this X-ray. When you draw this line, this angle, mechanical axis, it won't give the proper angulation of difference. It's the same patient, the long knee weight-bearing X-ray. If you see, the difference is so much, and the varus is mechanical axis is different. So that's why we need it. In X-ray, what are the checkpoints you have to see? Patella should face front. The yellow mark shows the patella facing front, and lesser trachea should be visible, but it should not be larger. The red mark shows the LT, and proximal tibio-femoral joint should overlap, and 1/3 of the fibula should be visible. That is the blue circle line we are marking the X-ray, and shape of the condyle looks normal. Femoral condyle looks normal. Though this is the same patient, scanogram was done in standing and supine. See in the left side, there is more varus on the standing X-ray when compared with supine X-ray. And this is one more patient X-ray with first X-ray shows the neutral with the patella facing center, and if the patella facing outward, it's externally rotated. If the patella facing out inward, so this is internally rotated. The varus, the alignment mechanical axis is different in all the 3 X-rays. So always the patella should be facing center. Long knee X-ray on weight bearing, it should be done. Standing X-rays. And if the leg, if the patient have shortening of the leg, we should keep a block under the shortened leg for limb length discrepancy, and better place a metal ball on the size of 4 to 5 centimeter at the level of the bone, which is the shorter, so that it may helpful in later correction, and it will good for the calculating the deformity. And Rosenberg view is most important and sensitive for diagnosing of osteoarthritis. So patient will facing the X-ray cassette with 45 degree of knee flexion, and the beam is formed from the cephalic and at 10 degree. So now coming to analysis of what are the frontal analysis, we should know the mole alignment by drawing the Mikulicz line. What is Mikulicz line? It is the line drawn from the center of the femoral head to the line to the center of the ankle joint. The mechanical axis deviation, the distance between from the intersection point to the black line shows the intersection point to the center of the knee is mechanical axis deviation. If then physiological axis, what is physiological? The percentage of the knee has to form in the center of the knee. The line should be mechanical axis of the leg should Mikulicz line should form in the center of the knee. We have to it can be between the percentage in the Fujisawa point, that is percentage of the tibia width to the 62% of width of the tibia. Then it should be from the medial to lateral, and if the value is less than 0 degree and the line in the minus 0 degree, it is the varus. If the line is for above the 100 degree, it is valgus. And regarding joint line congruency angle, the line we should draw a line in the articular surface of femur and articular surface of tibia, and the line should be the value should be either 0 or 2 degree. If the line is more than 2 degrees, there is a intra-articular problem in the knee joint, and it has to be corrected. So now from this diagram, you analyze the deformity. The MLD that is lateral distal femoral angle is 87, and medial proximal tibial angle is 72, and distal tibial angle is 97, and the mechanical tibiofibular angle is 21. That is he has varus deformity. In this, if you what need to be corrected, what we need to be corrected. So in this you can't correct, you can't tell that proximal correction or distal we can do open or closing with osteotomy. In this case, we have to draw a cora, that is axis from of the proximal part of tibia and axis for the distal part of tibia. The cora is 30 degree of this patient, and we should correct in the mid tibia. So regarding deformity correction, we should always look the analysis of the location of deformity, and the correction should be done at the deformity site. And today we are going to talk about the medial open cervical planning. So draw first, when you take a scanogram X-ray, you should draw a line, Mikulicz line, and if the Mikulicz line is more than 15 degree of medially, and it is obvious varus. And if it's more than 10 mm of laterally, it's more obvious valgus deformity. So for then we have to mark all the angles, proximal tibia, distal tibia, proximal femur, and distal femur angle. Then, so this is a case. After drawing the Mikulicz line, now I have given the value. Can anyone of the fellow tell where to correct the deformity? Fellows, can anyone say where is to correct the deformity? Seeing the values.
Both the MPTA is less, and also the LDFA is also on the lower side, so probably needs double correction.
So
it's more in the proximal tibia. So
in the proximal tibia, for this case, we are going to do we can correct the proximal tibia since the value is 82 degree. Now second case.
Both levels. The LDFA also increase, and
this is a double level.
Yes, both the levels we have to do in both distal femur and proximal tibia. If someone does in the proximal level alone, seeing the value, then it will go like this. This is a post-op. It will be like this only. Then case 3, seeing these values.
Probably an intra-articular loan. So almost normal disc femur and tibial angle. 84 to 87 is
Yes, intra-articular. So intra-articular H angle will be 0 to 2 degree, and its correction should be in the intra-articular correction should be done. So third step is the target alignment axis. The target alignment should be either in the middle of the knee and or in the Fujisawa line. So in the this is the line drawn. Mercurius line is drawn, and the target angle should be in the center of the knee. The image shows in the center of the knee, and this scanogram shows in the Fujisawa line of the same patient. So the osteotomy type and the inch. What is inch osteotomy? Medial open wedge osteotomy. So one transverse cut from the medial to lateral, and the inch on the inch should be on the lateral aspect. So open the gap from medial to correct the deformity. What is inch point? Inch point is nothing but from the 15 millimeter below the lateral tibial plateau and lateral joint line, and 10 millimeter medial to the lateral cortex. Line drawn from the medial to the point facing towards the fibular head and tip of the fibular head. This is the red mark shows the inch point. So coming to Miniachi method, the line drawn from the femoral head to the Fujisawa line, and the line. This is the correcting angle. The yellow mark in the tibia, from the tibia to the fibular head, and from the fibular head, that is fibular is the inch point. From the inch point to the correct point towards the correction of knee angle. This angle is called alpha angle. The angle which measured is should be corrected in the medial opening wedge osteotomy should be done in the medial aspect. So the image, the blue line, blue diagram shows the point where the osteotomy should be done in the medial aspect. So first we have to draw the Mercurius line and define the osteotomy type and location of inch point. Then draw the connecting between the inch point and the center of ankle. Then line rotate line should be until the cross the first line. That is, the first line is the second line. Number 2 represent the line of from the ankle to the inch point. The third line, number 3 represent the line from the inch point to the angle which we are going to restore, and just duplicate the angle alpha in the medial open type or middle side. Then if JC angle is more than 2 degree, we should self-correction of JC angle need to be taken from the alpha angle. A study done in 2019 by Lee regarding the medial open wedge osteotomy, he showed that higher inter and intra rate reliability in the preoperative correction angle and osteotomy gap. Next is Dugdale method. This is the method which was changed by Dugdale. This line drawn from the center of femoral head to the Fujisawa point, and one more line drawn from the center of the ankle to the Fujisawa point. This angle is measured at beta. So this is the correction the angle for the medial open wedge osteotomy. So surgical by Schroeder, he said that he had done a randomized prospective study for 3 years in 120 patient who for the unicompartmental medial underwent a medial open wedge tibial osteotomy. There is a difference between the planned correction angle and a postoperative corrected angle of using the method was 0.8 degree. Summary: full weight bearing long leg radiography is mandatory for planning. Be aware of correcting AP views. Deformity analysis by measuring all the angles and compare with the normal values. Analyze the location of deformity. Thank you, sir.
Thank you, Santosh. A very good presentation. Good, let's say, review, and good that you involved all the fellows. But shall we have the discussion after the next talk together?
Yes, sir.
Morning, sir. Am I audible, sir?
Yes, Praveen, go on.
So, morning, everyone. In continuation with Santosh talk, I'll be talking about double L osteotomies, dome osteotomies, and intra-articular PCVOs. So, to start off, just a quick summary of most important angles we should be kept in mind while planning a deformity correction. These are the systematic steps put forward by Pale with regards to any deformity around the knee. So, as discussed, we have to look for the hip knee axis, then the weight-bearing Miculix axis to determine the varus or valgum, and the mechanical LDFA and the MPTA to localize the deformity, whether it's in the femur or the tibia. And of course, additionally also to look for an intra-articular deformity and congruence of the joint by measuring the joint convergence angles. So the next question is why? What is the need to do a double level osteotomy? Why two surgeries when can be addressed with one surgery? So this the concept of the double level came up with regards to this mechanobiological concept, which just says that we need to preserve the physiology of the joint as much as possible without generating new deformities while addressing any deformity in any joint. So what they meant to see is they have to preserve the joint line obliquity. So what is a joint line obliquity? So joint line obliquity is nothing but the parallelity of the tibial articular surface with respect to the ground level on loading the joint. So this is the angle drawn between the articular surface of the tibia against the parallel level ground along parallel line along the ground. So normal value it should be in alignment with the ground. So it should be normally 0. Positive valgus of up to 4 degree on loading is acceptable. So normal value can be taken as 0 to 4. So a positive value implies a valgus deformity in the knee, and a negative value implies a varus deformity in the knee. So when lying supine on non-weight bearing, there is a natural joint line obliquity of 3 degree varus because of the normal alignment, as in the hips are widely spaced as compared to the angles on normal alignment. However, when the joint is loaded, particularly on the stand space of the joint line obliquity is neutralized and comes to lie parallel to the ground. So what are the implications of having an oblique joint line? So naturally, with further loading on an oblique joint line, it naturally causes increased and unnecessary shear forces at the joint. So this leads to progressive point loading within the point shear damage within the joint at particular places, at particular points, leading to progressive cartilage damage, and also an prolonged oblique shear force acting on the joint leads to ligament laxity in one compartment. And particularly with respect to postoperatively in high tibial osteotomies, the shearing forces causes the increased risk of hinge fractures, and also they can inherently destabilize the osteotomy construct and can pose problems for osteotomy consolidation. So how do we measure the joint line obliquity pre-operative? How do we plan for it? So this is initially it was put forward in 2019 by Park et al. In BMC journal, where they analyzed the multiple high tibial osteotomies, and they concluded that every 2 degree correction of the deformity leads to 1 degree increase in the joint line. However, this was later found to be not very reliable, and currently this study by same author published in OJSM in 2021. Where they show that the post-operative joint line obliquity is not equal to the pre-operative joint line obliquity plus the adduction angle. So what's the adduction angle? So this adduction angle is the line with. So this is the steps of planning to plan the osteotomy. So as you can see, this is the pre-operative Miculix line, and this is the expected weight-bearing Miculix line. Adduction angle is nothing but the angle between these two lines, this angle beta. So what happens is, post the osteotomy, when the patient actually loads and walks on the osteotomy limb, the limb goes into beta angle of adduction on loading the joint. So this inherently further cause an increased obliquity by angle of beta within the at the joint line level. So basically, the adduction angle of beta is added on to the joint line on loading the joint post-operatively. So the post-op joint line obliquity is the pre-op JLO plus the adduction angle. So when do we need a double level osteotomy? So as with any other osteotomy, there should be a good pre-op pain-free activity level to plan for an osteotomy. And joint line obliquity has a major implication. As of studies at present, major implications seen only in patients less than 60 years. More than 60 years, joint line obliquity doesn't have much functional implications. So it is ideally indicated of only patients with less than 60 years. And naturally, a double level osteotomy invariably is seen only in case of severe deformity involving both the lateral femur, lateral condyle femur and the medial proximal tibia. So that is, in other words, when the maculex line is not in contact with the knee, or if the hip knee axis is greater than 9 degrees. It can be done up to stage 3 OA, and yeah, the most important indication is an altered LDFA and an altered MPTA. Another way to look at this is there is a increased joint line obliquity of greater than 4 degree on an attempted preoperative attempted correction of more than on correction at one level. That again translates to in cases requiring more than 15 mm, which always requires almost always it's better will always alter the joint line mobility, so might require a double level osteotomy. So example, looking at this case, so I can see there's a severe varus deformity where the LDFA is minimally altered, but the MPTA is grossly altered. This is only 80, and there is a joint line intra-articular deformity. JLC is 6, and the pre-op JLO is 7. However, if you plan to correct this entire deformity at the medial proximal tibial level by taking a huge 20-degree correction at the proximal tibia, it will restore the alignment axis. But if you look at the other parameters, the MPTA is again it's not normal. It's grossly, it's rather increased and becomes 100. And the joint line obliquity is also from 7 degrees increases to 9 degrees. Hence, it is not ideal to correct this such a case just with a single level osteotomy. So the most definite indication for a double level osteotomy is a deformity in the LDFA plus the MPTA plus a joint line pre-op joint line obliquity of greater than 3 and a joint line convergence angle of greater than 5. So this is a study published by Sovan et al. In 2020, where they did the analysis of 130 open high tibial osteotomies, where they measured the angles perioperatively and postoperatively. Say they found that cases which require had both the preoperative, an LDFA as well as an MPTA defect, definitely need a distal femoral osteotomy. Those cases which have only one of these deformities, either in the lateral femur or the proximal tibia, the next step to be looked for is the joint line obliquity and the joint line convergence angles. Presence of any of these one risk factors, if just done with ITB, a single level osteotomy, immediately led to increase the joint line obliquity post-operatively. So based on that study, they are suggesting that if there's a risk factor of either joint line obliquity of joint line obliquity greater than 3 or a joint line convergence angle greater than 5, will most definitely require if both are present, will most definitely require a double level osteotomy. If only one of the risk factors present, it is subjective according to as per the surgeon and can be treated with either a HTO or a DLO. If neither of the risk factors are present, then can probably be done with just a single level. So again, to reiterate, the most important risk factor and definite indication for double level osteotomy is LDFA as well as MPTA deformity plus joint line pre-op joint line obliquity of greater than 3 degrees and a joint line convergence angle of greater than 5. So of the various permutations combinations, the most commonly naturally recommended technique is the lateral closing with distal femoral osteotomy and a medial opening with high tibial osteotomy. And naturally, a graft taken from the closing wedge should be ideally placed in the opening, placed and packed to the open wedge site. So this is an example of the same case if planned as per a double level osteotomy. So here you can see instead of taking a 20-degree correction at the proximal tibia, there's a 10-degree closing wedge taken at the distal femur and a 10-degree open wedge taken on the proximal tibia. So this ultimately restores the joint line of oblique to near neutral. So this is the idea of doing a double level osteotomy. So just quickly regarding the surgical technique of how to do go about a DFO. So naturally, first, if two-level procedure is contemplated, first thing to be done is a closing its site. The reasoning for it is that there is a less chance of loss of reduction at the closing its site rather than open its site following manipulation while doing the other side, other the bone. And if there is more correction needed, it can be easily accommodated by increasing the opening at the open wedge site rather than the need for taking additional cuts at the closing wedge site. And as discussed by Santosh, the intraoperatively the size of wedges should be confirmed by using the Herning table. This is a table put forward where depending on the size of the bone, and the degree of the deformity corrected attempted, the length of the wedge taken differs. So as you can see, if the femur is only 50 mm wide, even for 8-degree correction, you need only a 7 mm cut. However, if in a longer femur, it need as big as 11 mm cut. And just like is in HTO, biplanar closing with osteotomy is preferred. Primary reason being it provides better rotational stability. So how to go about identifying the landmark for distal femur osteotomy? The most consistent landmark is the vascular group present on both sides, on both the medial and lateral side. There's a transverse artery with 2 wings, which marks the starting point for osteotomy. They are richly separated collaterals and hence can be sacrificed if necessary. So once that location is identified, at the posterior 3/4 of the distal femur, 2 incomplete transverse cuts are made, forming an isosceles triangle so that they are on compressing on closing the wedge, they sit well appropriately. And the hinge is directed towards the point just proximal to the medial femoral condyle, up to 5 to 10 mm from the opposite cortex. This region is most ideal for the hinge since it corresponds to the origin of the medial gastroc, hence has adequate soft tissue cover on the medial side. And also since it also has good local bone, strong bone at this site, so hence is the most ideal site for hinge with respect to distal femur osteotomy. Following this step, an ascending osteotomy is done in the anterior 1/4 at a 95-degree angle to the transverse cuts. So as you can see, these are the transverse vessels can be used as
Rahul, can you check?
Yes, sir. He's connecting again, sir.
share again. So these are the vessels that can be used as a reference point for planning starting the osteotomy. And the isosceles shaped graft is equally placed base and both sides of the triangle graft is taken. And then the ascending osteotomy is done about 95-degree angle to the transverse cuts. Following it can be secured with the locking plate. So again, as discussed, the reasoning for biplanar technique is as better consolidation, better stability, and also to reduce the risk of trochlear damage by taking a cut perpendicular trochlear rather than along its line by completing the anterior osteotomy. So once the cut is made, the wedge is gradually closed under CM guidance till exact apposition is achieved. Again, once the wedge is closed, so as you can see, this is the first line play, first cut made. I mean, first drill bit placed at the hinge side. Then the measurement is made. Then the amount of wedge to be taken is calculated as per the chart, and then the wedge osteotomy is completed. Once this bone is removed, the wedge side is closely approximated and fixed to the distal femur locking plate. Again, point to be noticed, the sequence of screws to be applied. So the recommended technique is that once the distal femur plate is placed, one or two locking screws can be placed into the distal femur, distal fragment, and then compressive screw, bicortical compressive screw should be placed from the one of proximal distal most hold to the opposite side cortex. This is to hold the hinge and provide stability to the hinge till the fixation is stabilized. So this is also known as the gold screw. So it goes in a divergent direction away from the direction of the osteotomy. Once this screw is in place, the other locking screws in the distal fragments are secured first. Then the proximal screws in the proximal fragments are secured. And finally, this screw can be removed and replaced with the locking screw. So once the DFO is done, HTO is done as described by Santosh. So just again quickly on the technical note, ascending osteotomy is planned at 110 degrees to the horizontal, medially incision, medial inside incision, and release part of pencil to avoid paradoxical rise in pressure for unloading. Hinge zone, as discussed, is from the first tibial side to the circumference area of the fibula head. So again, a similar sequence of proximal locking screws, compressive bicortical screw, then locking screws. So the plate position should be placed as posterior as possible to prevent collapse of the slope. And if there is an opening of more than 10 mm is required, or patella baha is in descending papilla osteotomy is recommended. In case of descending osteotomy, additional fixation is recommended, either one or two anteroposterior screws. And bone grafting, if there is more than 10 mm opening, or other probable risk factors for healing, like smoking or obesity. So most common complications seen with respect to DFO as with any osteotomy is the hinge fracture. This is a classification of hinge fracture. So type 1 is in line with the osteotomy side, it goes into the tibiofibular joint. Type 2 and 3, type 2 goes below and type 3 goes above into the joint. So type 2 can be managed, type 1 can be managed conservatively. Type 2 and 3 will require additional stabilization at the hinge side with a small 3.5 mm plate. And possibility of non-union, again, the risk factors primarily being smoking or incompliance to post-op protocol and increased loading like in obesity. And also, as particularly, there is risk of populated injury both in
So the internet here is unstable. Is connecting again.
Okay.
Hello, sir. Sir is trying to connect now, sir.
Very sorry for the delay, sir. So as discussed, in the DLO cases, chemoprophylaxis with up to 3 weeks is recommended. So this is an example of finally done HT double level osteotomy planned using soft as available when where the scanogram is spread and it comes up with the deformity angle and the LDFA and MPT angles. Following this, the deform correction can be planned to restore the joint line obliquity. So moving on to the next type of osteotomy, which is the dome osteotomy, also known as the barrel vault osteotomy, primarily used for larger deformities of greater than 50 degrees and chronic knee subluxations. Popularized in the 80s, primarily as a diaphyseal non-union correction technique, but however is not routinely preferred at present. So with respect to dome osteotomy, there are two types. One is the conventional osteotomy, which can be planned for intra-articular varus deformities, focal deformities for diaphyseal malunions. So in the conventional dome osteotomy, it is a deformity at the knee joint. So the cora is at the knee joint in the proximal tibia. And hence, in such cases, the deformity correction is done outside with the concave directed distally. Whereas in a focal dome osteotomy, where the deformity is at the proximal tibia metaphysis, the scora is in line with the area of the dome. So in such cases, the dome is planned with the concave directed proximally. Invariably, while doing focal dome osteotomy, fibular osteotomy and distal transport to provide stability on the lateral side is required. Usually done with using a ring fixator and primarily used for diaphyseal malunions. So just quickly regarding the dome osteotomy for intra-articular deformities. So initially described techniques were as such, like where the pins were placed at an angle to the desired angle of correction to the tibial plateau and then brought into parallelity to achieve the reduction. And then osteotomy is also, fibular osteotomy also invariably needed. At present, this is a technique being followed as per paper published in 2019. So where the pins are placed in first pin is placed parallel to the plateau and second pin is placed using a goniometer, and then the correction is achieved and fixed with a definite fixation. And instead of a fibular osteotomy, tibial fibular osteotomy is tibular fibular layer of tibular bone is taken off to allow movement at the proximal tibia. Just quickly, instrumentation required. This is the goniometer required to play, which can accommodate the stainment pins, X-fix, and this is the cutting guide and the locking place in a step-by fixation. So, in contrast to other types of osteotomy, this is a quite expensive osteotomy and requires extensive midline incision from the middle near inferior pole of patella to the 5 centimeter below the tibial tuberosity. Anterior compartment fasciotomy is routinely required, at least in the distal part. And the initial cut taken is at the tibia-femoral junction to allow movement of the proximal tibia. Once this is done, the curvilineous glide is placed underneath the patellar tendon. So as can be seen here, the dome is cut using this guide. So multiple drill holes are made along this guide, which are then later connected. Then first stainment pin is placed using the first screw hole of anterior and proximal screw hole of the plate. So using a plate as a reference, first stainment pin is placed. And following is the osteotomy is completed at the dome using an osteotome. Care to be taken not to complete the osteotome. Posterior contrast left intact at this point. Then the distal pin is placed with again a plate as a reference, just anterior to the plate, so that the plate is pushed adequately posterior to prevent collapse of to prevent changes in the slope. Again, this is placed with using the goniometer. As you can see, in this goniometer, the preformed angle of correction can be predetermined, and that will angulate the pin at the set angle. So to achieve the correction, basically we just have to try to get these pins into parallelity, and that will achieve the necessary correction. So once the second pin is placed, the posterior osteotomy is completed. Care to be taken goes perpendicular to tibia to avoid slope alterations. And once the osteotomy is complete, it is freely mobile, and manually valgus corrections applied till the pins are parallel. Parallelity is confirmed by measuring the pins at the proximal distal site. And once the pins parallelity is achieved correction is found to be adequate, pins are held with an X fix, and the plate is recounted for the new corrected proximal tibia and fixed with the locking screws. So I can say held with the X fix, and then the plate is placed and other screws are secured. So what is the main advantage? So it does not alter the natural shape of the proximal tibia with respect to closing edge or open bridge, and also does not affect the patellar position at all. So the native patellar position is maintained, and also in contrast to opening or closing wedge, the length of the tibia is maintained. Since there is a large amount of metaphyseal bone in contact with each other at the dome site, it shortens the bone healing period, and naturally has no recurrence for additional bone grafts, since there is very good metaphyseal bone being in contact. Compared to other HTOs, it has an easy conversion to TKRs, and as discussed, is primarily indicated for larger correction angles, and can also be used in cases where there is a failed HTOs, particularly when lateral close with failed HTOs. Our complete disadvantages, as discussed, a more morbid procedure requiring larger exposure. While completing osteotomy, posterior neurovascular structures are at risk. The tibio-femoral joint disruption can theoretically cause increased posterolateral laxity on further loading of the joint. Technically, little more demanding as compared to conventional HTOs, and there is also a risk of damage to the patellar tendon. So moving on to the next osteotomy, which is the TCVO, which is just nothing but a type of open edge osteotomy, but restricted just to the medial tibial plateau. It's also known as a Chiba osteotomy or the L-shape osteotomy. So primary indications, it is unlike the other osteotomies, it's primarily indicated for a minimum scale grade of 3 and above. And also with respect to the contour of the tibial plateau, it is particularly indicated for the pagoda type. So this is the types of tibial plateau classified as flat or depressed, where the contact surface are towards the middle of the tibia, or pagoda type, where they're directed away from the tibia. So basically, for a TCO to work, there should be adequate room in the lateral compartment for the tibia to accommodate itself on correction. So which is definitely is not possible in the depressed type, since this will start to hinge if the correction is attempted here. So the depression type is a definite contraindication for TCVO. It is primarily indicated for pagoda type, which has enough room on the lateral compartment to accommodate the correction. How in the flat type also it can be done, provided there is excessive laxity, which can be assessed with stress views. So other indication is findings in indicator of intra-articular deformity, that is JLCA of greater than 5. And as with other osteotomies, FFT less than 50 and adequate range of motion should be present. And there is no implication of age with respect to TCVOs. There is good results have been seen with most cases, irrespective of age. So what are the contraindications? Any ongoing infections, inflammatory conditions, any Charcot's or avascular necrosis changes at the knee joint. So what are the angles to be considered with the theory of TCVO? with respect to planning TCVO. So primarily, in addition to the other measurements, two angles is the alpha and the beta angle. So alpha angle is nothing but the conventional measurement you take using a Michaelis line, and the beta angle is 1.5 times the varus stress joint length CA plus the valgus stress joint length CA. So point note is the beta angle is indirect measure of the mobility or amount of deformity that can be accommodated within the joint. The factor of 1.5 is arbitrarily included to say there is a soft tissue, the account for elasticity of the soft tissue basically. So if the beta angle is greater than the required deformity correction angle, then the entire deformity can be addressed only with the intra-articular osteotomy. So only a TCVO is sufficient. However, if the required correction angle is greater than the beta angle, it needs an additional extra-articular procedure. Depending on type of the osteotomy, it can be either in the proximal tibia or the distal femur. Try to explain this better with the two examples. So as we can see here, this is case number 1. So this is the alpha angle drawn, measured, attempted. This is a measured correction angle of 11 degrees. So this is the varus and the valgus stress JLCS. Varus stress was 9 and the valgus stress is coming back to a valgus position, so -1. So the beta angle is measured as 1.5 times 9 plus -1. So 1.5 times 8, that is 12. So the beta angle is more than the alpha angle. So whatever correction required can be accommodated by correcting at the intra-articular level. So only TCVO is sufficient for this case. However, with a similar case with a slightly different parameters, say like a more exaggerated deformity where the alpha angle is 14 degrees and the varus stress angle JLC is 6 and the valgus stress is -1. So as you can see, the beta angle comes out to be only 7.5. So the alpha, the required deformity correction is more than that can be accommodated within the joint. So an additional correction should be planned for using extra-articular osteotomy. Since in this case, it primarily seems to be MPTA deformity, an additional open-edge high tibial osteotomy is done. So again, surgical technique very similar to conventional HTO. Medial side PES insertion MCL is recommended to be detached to avoid paradoxial loading. So with the guide towards the hinge point, that starting point is marked, and along this line, transverse, the apex is marked using anteroposterior K wire at just medial to the medial border of the patellar tendon. Once this is done, a vertical cut is made using a chisel along towards from the apex to the eminence, following which posterior cut is carefully done under CM guidance, following which the transverse cut is done. Once the osteotomy is completed, the fragments are held in place with using 2K wires. Another correction is achieved using the laminar spreader. Once the adequate correction is achieved, it's fixed to the locking plate. So most important questions: how do you know you achieved adequate correction? So this is basically only an intra-op measurement. So idea is to distract the medial compartment enough so that both the lateral and the medial tibial plateaus are in contact with the distalmost point of femoral condyle, as in the joint is maximally distracted. And following this distracted portion, the joint should be stable in varus and valgus stress. That is, there should be no laxity on either side. If there is instability following correction, it is usually due to either an inadequate medial release or there is inadequate opening at the osteotomy site, or very rarely fracture at the lateral condyle. If TCVO is done with the opening of greater than 25 mm in severe deformities, circular fixators might be needed, and bone grafting usually recommended for TCVO. So coming to the primary advantages, so it is a intra-articular procedure addressing intra-articular deformity. So primary advantage being the amount of deformity, the amount of correction required to correct the deformity is less as compared to an extra-articular deformity. And secondarily, the joint congruity is also improved, and the joint line obliquity is also addressed concurrently. And just like in HTO, weight bearing can be allowed, and even more so earlier than in conventional HTO, since one side of the tibia is left untouched, and the patellofemoral changes are less compared to open edge high tibial osteotomy, and reduces also provides more stability to the joint, so helps in better loading of the joint post-operatively. Primary disadvantage is the Angle of valgus corrections are limited by the beta angle measurement. There is how much the joint can accommodate can be corrected using this. Greater angles cannot be corrected. And if needed for the second procedures, meticulous should be planned for and meticulously in the pre-op planning. Since the intra-op correction, if found inadequate, can't salvage otherwise. And in patients with pre-op lateral thrust gate, TCU has shown poor results. So take home poor message. So any osteotomy correction, primary work is systemic pre-op workup to go systematically locate the deformity and plan for the deformity. In addition to the other factors, the new factor to be considered is the joint and obliquity. And the most definite indication for double osteotomy if there is a deformity at the lateral distal femur as well as the MPTA, and the joint line obliquity is greater than 3 and JLCA greater than 5. Dome osteotomy is indicator for larger deformities, but technique more challenging and morbid and not totally done. So with respect to TCV, two angles to be kept in mind. If the beta angle is greater than alpha angle, TCV alone is adequate to correct the deformity. If the correction angle is more than beta angle, it requires an additional extra-articular procedure. Thank you, sir.
Thank you, Praveen. Elaborate talk. Had to cover a lot of things. Already 8 o'clock. Okay. So I'll share my screen before. Initially, Santosh presented really well. For any scanogram, you take an AP, and Santosh, did you mention about the lateral scanogram? So
No, sir.
can you see my screen? Is my screen visible? I hope you see my screen. So for any scanogram, we have to take a lateral scanogram also. So that's the study which we have done, and there are a lot of points which you can take. A lateral scanogram gives us the FFD is there or not, and it is mandatory to have a full-length lateral scanogram so that you can pick up certain things which are not picked up in the conventional X-rays. Are you able to see my screen?
Yes, sir. Yes, sir.
But I'm not able to run through my slides.
Play, sir. Play,
One minute.
sir.
Okay, let's not waste time. So for any scanogram is the one which will pick up deformities which are not exactly closer to the knee. I wanted to show an X-ray. Apart from that, DFOs, Praveen, DFOs, if there is a rotational deformity with a coronal plane deformity, how to address it?
With the that should be planned according to the address the coronal plane deformity as well.
Yeah, what will you plan that study? There is if there is suppose there is a valgus of 20 degrees. LDFA is 75, and there is an additional rotational deformity of about 20 degrees of internal rotation. Femoral anteversion is increased. So how will you address that?
The wedge should be planned such that it is converging on the anterior surface and diverging on the posterior surface. I mean, not sure, sir.
No, that's not. Anybody else, fellows?
By dome correction, we can correct simultaneously the rotation of it.
How will you do the dome correction?
Dome ostomy, we can rotate it simultaneously along with the coronal.
That's one option. Correct. Dome osteotomy, planning and surgically it will be very difficult. Other option is to do two osteotomies together. One is the DFO and a proximal level femoral rotation osteotomy. That is the textbook description, how you should address, or you have to do it in staged, where rotation is corrected in the shaft level or higher, and DFO is done at the distal femoral level. That's a description. But we have a description where we did a DFO which had a rotational correction also, which is our publication. You can, I think it's in publication. You can go through and see that is available. Apart from that, I really wanted to show one slide. Okay, can you see this?
Yes,
So
sir.
with this X-ray, what do you think would be required? How much varus?
Yeah, seems to be
So
an
that view gives a clue that something is going on little distally. So this is the importance of actually taking a full length scanogram, which will give us the total picture of where exactly the varus is. So much of varus, about 25 degrees of varus, which is quite in the middle third and proximal third junction. So how would you deal with this varus?
the focal dome osteotomy at the diaphyseal site.
Yeah, I know you would answer that, but how do you plan? How would you do the focal dome? Where will be the dome? You did tell
Draw the cora, sir. Draw the
The
cora from
diaphyseal, it can be taken at the level of the core. It can be done just at the deformity, sir.
the deformity.
Yeah. Good. But a doom, which doom can be inverted doom or a doom. Would you do a doom or an inverted doom? I mean that arc.
Yes, the concavity is directed
Where
from
the
inverted
concave
doom.
be? Why inverted doom?
That can, since that will accommodate the
Correctly, accommodate the
cora, like within the concavity.
okay, because you trace it and you check which kind of doom will work well, and where the cora will be closer, and where is the malalignment. This is an oblique fracture probably, so the fracture is running one side, and you have to align the outer cortex. So one cortex. When you align the cortex, you would have a overlying bone. So when you have that overlying bone, you have to if you do this is an inverted dome. If you do a dome other way, there would be overhanging of the bone, too much of overhang.
Okay.
So if at all you have an overhang, you have to slice that bone which is overhanging, and you can use that as graft on the other side. This is one of the ideal indications for dome where the angle is high and the cora it is it is away from the HTO. If you do a HTO, it would be a wrong indication to a HTO. So this is one of the examples where planning is very important. And talking about planning, Santosh, you told about the Fujisawa point selection. You did mention about the third factor which you mentioned. What exactly is that? Where exactly the final alignment should fall? What is the term you used for that? I forgot.
Line is alignment should for the line mechanical axis should go through the 62% of the tibial with the length of the tibial plateau, sir. That is in the Fujisawa point, sir. From the medial to lateral.
Yeah, but isn't all cases you choose the Fujisawa point, or it is variable? 62%.
Sir, it's variable, sir. If young patient active and cartilage is okay, we'll go in the midline of the midline knee, the midpoint, sir. If it is cartilage is severely OA and we'll in the older patient, we'll go on the Fujisawa point.
Yeah, correct. All these factors are based on double leg stance scanogram. So scanogram itself is a little controversial whether you have to take what we do for a weight bearing X-ray, single leg stance, whether we should do two single leg stance and stitch it together, or double leg stance, or is it with the stress X-rays which you should assess. So that is a controversy here, because with the stress, and if you give a valgus or a varus stress, all the angles will change. So final output should be what is there on a full weight bearing view. So your calculations it's always better to undercorrect and check with varus and valgus stress and drop to give the fine tuning. So, but the teaching is that you plan pre-op. What is the exact pre-op degrees you get? You have to produce it in drop. But I would disagree, because there's a lot of changes with ligament laxity when you release the MCL, and intraoperatively you might need to adjust it. And did you talk about the slope correction, Santosh?
No, sir. I forgot.
Are we having another talk on that? Okay, we will discuss about slope correction another day because already 8:10. Sir, your point, sir. Good presentation, both of you.
Thank you, sir.
Nothing that the presentation being good. And keep it up. Nothing for me to add. Thank you.
Thank you, sir.
Good morning, sir. Is my screen visible and am I audible, sir?
Yes, sir.
Yeah. Good morning, everyone. Today I'll be talking about lumbar interbody fusion. So, coming to introduction, lumbar interbody fusion is an established procedure for various spine pathologies, including the degenerative disc disease, deformity correction, infection, trauma, and tumors. The goal of interbody fusion is the elimination of pathological segmental motion and accompanying symptoms. Successful interbody fusion results in arthrodesis, and non-union it results in pseudoarthrosis. Lumbar interbody fusions mainly involve 3 steps where there is a removal of intervertebral disc, preparation of the end plates, and placement of different type of implants, which are mainly cages or autografts. The main objectives of the interbody fusion remains to restore the intervertebral space, stabilize the segments with proper height, and regain the lordosis. Coming to approaches, lumbar interbody fusion is done in various 5 approaches. Mainly, it is reached through anteriorly, oblique lumbar interbody fusion, or it's just anterior to the psoas approach. Lateral lumbar interbody fusion or extreme lateral interbody lumbar fusion, and most commonly it's approached posteriorly and through transfemoral routes. Coming to evolution of the lumbar interbody fusion, Burns and Kapner reported the first interbody lumbar fusion in 1930. Later, Briggs and Milgan in 1944 first started with a posterior lumbar interbody fusion, which was later evolved by Clovard in 1950s. Steffi and Stikowaski shared the load sharing concept in 1988, where using the pedicle screw system, the low compression at the graft site was introduced. Harms and Rollinger in 1982 introduced the transfemoral lumbar interbody fusion as an alternative to the posterior lumbar interbody fusion. And with recent technical advances in the surgical instruments, minimal invasive surgery started to appear as an alternative to open surgeries. Nowadays, to avoid disruption of posterior spinal structures, minimal invasive surgeries mainly include the anterior lumbar interbody fusion, oblique lumbar interbody fusion, and the lateral lumbar interbody fusion. Coming to the posterior lumbar interbody fusion, it was the first technique employed for the interbody fusions. The intervertebral disc brace approached posteriorly. In this procedure, proper positioning of the patient is essential. The patient is positioned prone with a bolster supported on the pelvic support and the lower chest ribs. The important aspects being the elimination of the intra-abdominal pressure. The eliminating the intra-abdominal pressure decompresses the epidural venous plexus, which reduces the intraoperative bleeding. Coming to the surgical aspect, after marking the operative level at the CM, midline incision is taken. Soft tissues are dissected, and through subperiosteal approach, the posterior elements are exposed. Wide laminectomy is done, including the rostral part of the upper vertebra and the caudal part of the vertebra, exposing the neural elements, thecal sac and the traversing roots. Then, after carefully retracting the thecal sac and the traversing roots, the graft site intervertebral disc space is approached, and the graft site and intervertebral disc space is approached and preparation of the disc space is done. Care is taken to remove the only cartilaginous end plates, not the bony end plate. And once fixation, once the graft is introduced and the implant cages are introduced, transpedicular fixation is done for the stabilization of the segments. The advantages with the posterior lumbar interbody fusion is that it's a traditional approach with access to the anterior and posterior columns of the spine. Visualization of the neural structures is clear, and in a single approach, bilateral decompression can be done. This is familiar with most surgeons, and a 360-degree potential fusion can be performed with a single posterior approach, and adequate interbody height restoration can be performed in the single approach. Coming to disadvantages, the most common disadvantage being the paramuscular injury due to prolonged retraction of the paraspinal muscles. Since there is an exposure of the neural elements, thecal sac, this procedure is limited to the lower lumbar levels from L3 to S1 level. Due to chronic retraction of the nerve roots, it may result in fibrosis or chronic radiculopathy. Since it's a open surgery and wide laminectomy is found, there will be a delay in mobilization and recovery in the post-operative period. And since the posterior neural elements are exposed, dural injuries are much more prone. Coming to indications, posterior lumbar interbody fusion mainly indicated in degenerative disc disease, segmental instability, spondylolisthesis, recurrent disc herniation, failed back syndromes, and pseudoarthrosis. One of the most common contraindications where to avoid PLIF is epidural fibrosis, active infection, severe osteoporosis, and arachnoiditis. Coming to transforaminal lumbar interbody fusion, Harms and Rollinger in 1982 introduced TLIF as an alternative to the posterior lumbar interbody fusion. The main part was accessing the intervertebral disc through a lateral trajectory, then the direct posteriorly approaching the intervertebral disc. Position and approach remains the same as posterior lumbar interbody fusion. Foley et al. Introduced the minimal invasive technique for TLIF in 2000, mainly to related to the approach related complications in the conventional posterior approach. This is Cambian's triangle. Cambian's triangle is a safe transforaminal corridor to the intervertebral disc, which is mainly bordered by the thecal sac medially and inferiorly by the upper plate of the lower vertebrae end plate, and laterally by the exiting nerve root. Advantages of the TLIF is a 360-degree fusion in a single incision. It reduces the retraction of neural elements, which is one of the most important advantages. The upper segments of the lumbar spine can be approached where it can, where there is no much retraction required. Less damage to the posterior ligamentous complex with preserved biomechanical stability. It is one of the preferred procedure for revision surgeries. As revision surgeries, there will be much of epidural scarring and avoids the scarring area, and there is low risk of durotomy happening in this procedure. Coming to the disadvantages, again, there will be always risk of paraspinal muscle injury. Since TLIF approach is through unilaterally, there will be an incomplete removal of disc material, and this studies have shown that incomplete removal of disc material decreases the fusion rates. Coming to the indications and contraindications remain the same as for the posterior lumbar interbody fusion. Now, since with the advancement in the techniques, minimal invasive surgery techniques have gained popularity. Coming to anterior lumbar interbody fusion, it is efficacious and predominant surgical technique, allows comprehensive discectomy and a direct implant insertion. Both the transperitoneal and retroperitoneal approaches are involved. Transperitoneal approach involves more risk of bowel injury, ileus, retrograde ejaculation, and is limited to L5S1 segment. Here, the position of the patient is placed supine. Approach can be either midline, paramedian, or mini phalansteal with retroperitoneal corridor, sir. After taking the incision and careful inspection, finger dissection is carried out through transversalis fascia, and the arcuate line is identified. Once finger dissection is the landmark identified is the psoas muscles with pulsations of the common iliac artery. Once that is found, the finger dissection is further forwarded, where we can palpate the L5S1 promontory and sacral promontory, and here will be the disc space available for us. This is the transperitoneal approach. Coming to the rationale of anterior lumbar interfusion is interbody fusion devices is used to redistribute loads to normal ratio. In a normal spine, the loading takes it's a 80-20 ratio, where the anterior and the middle column takes the 80% of the spinal loads, and posterior elements take up the 20% of the loads. In any spine pathologies, there is an alteration of this ratio, where 60%, usually 60% of the load is taken by the anterior and middle columns, and the load increases on the posterior elements. So the rationale main being the interbody fusion device is used to redistribute loads back to the normal ratio. Fusion potential increases when the graft is placed under direct compression under the anterior column, which is the Wolff's law. And then height restoration in focal and lumbar lordosis will be better be restored in anterior lumbar interbody fusion. The advantages being it's a less traumatic access than the posterior approach. There is a shorter hospital stay and less post-operative pain. Surgical site infection and nerve injuries are less in LF, as various studies have documented. It can be used in a failed posterior surgeries. Large interbody grafting can be done, and more lordotic cages can be placed to maintain the sagittal alignment. Again, the pitfalls here is mainly the approach related, where we have to mobilize the great vessels. Since great vessels have been mobilized, there will be a chance of deep vein thrombosis and a direct injury. There is always risk of abdominal injury and ureteric injury. Since it's an anterior incision, incisional hernia is one of the complications, and retrograde ejaculation with the injury to the hypogastриc plexus is seen. Indication for ALF is or more like a degenerative disc disease, failed posterior fusions, and post-operative spondylodiscitis cases. Contraindications mainly being a patient with morbid obesity, any prior abdominal surgery, or any prior radiation therapy. Aortic atherosclerosis also means one of the contraindications for the anterior approach. Coming to lateral lumbar interbody fusion, it was described by Osber et al. In 2006. This is the access, it mainly tells the access to the disc space via lateral retroperitoneal transverse corridor. The corridor is limited superiorly by the 11th or 12th ribs and inferiorly by the iliac crest. Here, the access is possible from L1 to L2 disc to L4 and L5 disc. Here, the position of the patient is left lateral decubitus or right lateral decubitus with hip and knee inflection. After marking the required level of operative level, a lateral incision is taken with dissection of the abdominal musculature. Here, through finger dissection, retroperitoneal space is identified by the presence of yellow fat. The finger dissection is carried out in the same way, sweeping the peritoneal sac anteriorly, and quadratus lumborum muscle is palpated and pushed posteriorly. After dissecting the muscles, we'll be directly reaching the lateral part of the disc base, and tubular, after marking the level, tubular retracts are placed on this level. The advantages being it minimizes soft tissue injury, decreases blood loss, and a shorter hospital stay. Deformity correction is better with large lordotic cages. This also helps in indirect compression, wherein there is an increase in the height of the foramen and increases the area of central canal. Disadvantages being the psoas injury, bowel and lumbar plexus injury, lower extremity, there is documented evidence of lower extremity weakness and paresthesia, incisional area, and vascular injury. Again, the indications being the degenerative disease, scoliosis correction is better, spondylolisthesis, any adjacent segment diseases, and post-laminectomy cases. Contraindication being any prior retroperitoneal surgeries, infection, past radiation therapy. L5-S1 disc pathologies can't be addressed with lateral lumbar interbody fusion because the iliac crest obstructs the view. Any congenital stenosis or sequestered disc is also a relative contraindication. Then coming to oblique lumbar interbody fusion, it was described by Michael Myers in 1977. This is a minimal invasive surgery where the access to disc space is between the peritoneum and the psoas muscle. It is suitable for L5-S1 level pathologies. Since there is a retraction of the psoas muscle, neural monitoring is not necessary. Again, the positioning is the same as we do in the lateral lumbar body interbody fusion. The working space will be between the inferior vena cava and the psoas. More or less, the OLIF is approached through left-sided approach. The advantages again here in this, it's a minimal invasive surgery with rapid post-operative mobilization. Aggressive deformity correction can be done. High fusion rates with comprehensive disc-based clearing. There is less chance of psoas injury and lumbar plexus in this procedure, and can target the L5-S1 level. Disadvantages being the vascular injury or sympathetic chain injury. Coming to the recent trend, like the endoscopic lumbar interbody fusion, it's more the most common procedure performed through endoscopic interbody fusion is the transforaminal approach. It uses a biportal endoscopic system, mainly involves the console, camera, and endoscopic irrigation system and toolkits. Radio frequency consoles mainly uses console probes for cauterization and bleeding control. There are two working channels. One will be the working channel, and there will be an endoscopic channel. Position remains the same as in TLE for any posterior lumbar interbody fusion. There are promising postoperative outcomes with lesser postoperative pain and shorter duration of stay. Still, the indications. The indications and contraindications are evolving. The inevitable obstacle is to overcome, and surgeons have to reach the learning curve for the endoscopic interbody fusion. Various studies have done when they compared to the options and levels, and based on the anatomy axis, following options are suitable depending on the lumbar level performed. So posterior lumbar interbody fusion is easily done at better accessible at L5-S1 or L4-5 or in the lower lumbar regions. Same as it is with the transforaminal approach. The anterior lumbar interbody fusion mainly more concentrates on the L5-S1 region and the L4, L5 levels. L5-S1 is a strict no for lateral lumbar interbody fusion, whereas the above level segments can be approached easily. And OLIF is also the same track as lateral lumbar interbody fusion. Coming to conclusions, interbody fusions are a proven effective treatment for venous spine pathologies. Many approaches are available, with each one having its own pearls and pitfalls. The optimal approach should be chosen based on the individual's pathology and anatomy and surgeon's familiarity with the available options. Thank you.
Dr. Sriram there for summarizing.
Yes, sir. So basically, he has covered all the approaches. We have seen this. Any questions from others, we will be ready to answer. So, Vishal, did you get any paper on the minimal axis approach that we use?
On the paper, sir, as such, this thing not biportal thing, not this thing, sir.
Not biportal, not biportal. Biportal is just evolving. Hardly only 2 people are doing it in India, and that one, this thing. They are still have to come out with the results and all.
Okay.
Not the biportal, the lateral approach that we use. Two incision approach that we use to go in. Do you have any long-term results on that?
I didn't get, sir, but fairly it's like similar results have been documented, sir, but as such paper I have not found, sir.
Yeah, because I'm yet to find out a paper purely on that.
Okay.
But we have a follow-up, so we'll follow it up. We'll see later.
Yeah.
Sir, I think Santosh is not there, sir. So,
Yeah, okay, you can close the meeting.
yeah, thank you.
Thanks, Gopal. Thanks for joining, and good night. Did I disturb? I'm a fool.